So good afternoon. Sorry for this short delay. So as you said before, I'm Galia Balkai. I'm a pediatrician in Sheba, and I'm heading the pediatric infectious disease unit. So I'm coming from the medical part. I'm a doctor as well, but I'm also heading telemedicine in Sheba for several years. In the first part of the presentation, I would like to talk to you a little bit of what we did with telemedicine, how we harnessed telemedicine tools to deal with COVID-19 in Sheba. And if we have some more time, I can talk a little bit more about our future dreams of telemedicine and what we're doing these days to plan for the future. So just a little bit of background around about Sheba. So Sheba is the largest hospital in Israel. It has 120 departments and clinic, almost 2,000 beds, with more than 7,000 healthcare professionals. Very big. It's situated on a 150-acre campus, and it's really the biggest and busiest in Israel. But not only the biggest, it also received recent recognition by the Newsweek as being nominated for the second year already as being one of the 10th best hospital in the world. It's the only Israeli there. And if you see the list of this year, we were on the 9th place after some very, very good hospitals from the world, Mayo, Cleveland, Mass General, Toronto, etc. Most of them are American, so we're really proud of it. And some of this recognition is due to our innovation, due to Sheba's innovation. And actually, a few years ago, we've developed a new concept for medical innovation. We've opened a new center for medical innovation in Sheba that's called ARC. ARC for Accelerate, Redesign, and Collaborate. So we want to accelerate innovation in Sheba in order to redesign healthcare, and we have an open campus for collaboration with hospitals and companies from around the world and Israel, and we really want to create an ecosystem which will change the future of medicine altogether. So we have in Sheba's ARC 6. Now we're having the 7th one, which is a Corona hub. But we had 6 hubs of different parts of innovation in Sheba. We've transferred. Sheba was innovated for many years before, but it was more on developing drugs, developing machines that have to do with medical innovation, and we've shifted more for digital health as the new world comes. So we've developed 6 hubs of telemedicine. The first one is personalized medicine. It's more about genomics, proteomics, patient-reported outcomes, etc. We have a big hub of big data and artificial intelligence, in which we're trying to develop predictive analytics, decision support systems, and digital imaging analysis. We're also having a hub for virtual reality and augmented reality, for training and simulation, for enabling surgery and therapy, and we collaborate as well in telemedicine. We have a hub that's dealing with operating rooms of the future. It has to deal a lot of with the robotics and automation, next generation anesthesia. We have a hub for rehabilitation, in which we're doing a lot of remote rehabilitation and smart personalized rehabilitation. And my hub that I was dealing with for the last few years is telemedicine, in which we try to open new services and to use sensors, wearable, and Internet of Things, and also develop programs of hospital at home. So in the last few years, we've developed several services in Sheba that have to deal with telemedicine. We have developed a feature of rehabilitation, a software of rehabilitation called Rehability Online, and it's also already present as a service that does a lot of treatment, physical therapy, occupational therapy. We had virtual clinics. We have cardiac rehabilitation, which I'll talk maybe about later on. We've developed telemedicine courses and also teleteaching, which is a way of teaching students using telemedicine tools. We've opened a new service a year ago of psychiatric continuous home treatment, which serves as acute hospitalization service and also an ongoing service for a whole year. And we've started doing home hospitalization for elderly in their homes. In addition, we do some patient-reported outcomes measures using our platform, and also we've used telepresence robots. But we did all this for the last few years, but telemedicine did not hit the mainstream of medicine, and we had to struggle with a lot of challenges that prevented our services to become very prominent. So we had problems or challenges with positioning video visits as equal to frontal visits, either from the patient side and from the caregiver side. We had to create a good user experience for both patients and caregivers. We had to find reimbursement models. This is not easy because telemedicine until a year ago were not reimbursed by Israeli health funds. And we had to create flexible models for clinicians to be reimbursed for this extra work. We had a lot of regulatory and privacy issues, and we had to choose the appropriate technologies. So these were part of the challenges that we dealt with before Corona. And then came Corona. Our story with Corona started on February, in mid-February, when there was still no Corona in Israel, COVID-19, but the Prime Minister decided to bring back some Israeli citizens that were on the Diamond Princess cruise ship and were exposed to COVID-19. We feared some of them did contract the virus and we still didn't know, and we decided to bring them back to Israel. And we understood that we had to create a separate facility for them, not inside the hospital. There was a big fear of COVID-19, and Sheba took the mission upon itself and decided to bring them back. We had only 3 days to get ready for their coming home, and we immediately understood that we had to create a new concept. And the new concept of hospitalization now meant something that we were not used to. We wanted to protect our crew from getting infected with the disease, and we wanted to maintain our high level of medical care that we usually give to our patients. But on the other side, we wanted to prevent, to decrease the minimum, the physical contact with the patients. And that's where we understood that we are going to use telemedicine to do a new thing. We wanted to do inpatient telehospitalization, where the goal was almost zero physical contact. Prior to that, we always used telemedicine platforms or services for patients that were distant and were not able to come to us. So it was the first time where we used telemedicine tools to provide care for inpatients, and that was a new model. So we had some challenges there too. We could not choose the patients. We knew the patients were chosen already. Most of them were not very young. We didn't know if they were literate or health or tech savvy. We didn't have the time to train them in advance, to show them the technology and train them. We didn't have time to train the clinician because we only had 2 to 3 days. We knew there was no drawbacks. Once we get the patients, they're inside, we cannot say, okay, it doesn't work. So we understood the patient engagement was critical. So what I did was the day after, I called all the companies in which we were already talking, but many of them we were not working with. We had our platform, which was Datos, but other companies that we knew were dealing with remote sensing or physical examination or communication. We called them all together and said, let's find a combination of these platforms or tools to try to do our best to treat these patients from distance. And that's what we did. We located all the patients in a distant, in a facility that we transformed into an actual internal medicine unit or ward. This was a students, a facility where students were located and slept. And we opened outside of it. We inflated a tent that usually serves us as a field hospital, and we called it the teletent because this is the place from where our staff did their medical job. Okay, so as you see, we gave them the monitors, the screens. They had their the radiology getting there, the EMR, and they were able to do all the things that they do from outside without the need to get inside and actually treat the patient, as long as they were stable. It raised everyone was interested in it. Even the Prime Minister and the Minister of Health found it interesting and came to see how it works, and we showed it to them. So how did we use, how did we harness the technologies to help us treat these patients? We knew we had to do three major things. The first and most critical was communication, because we knew if we could not communicate very well with the patients, it would be hard for us to treat them. Then we wanted to monitor them. And the third thing we wanted to do was physical examination if they became sicker. So for communication, we, of course, left in the rooms regular telephones. We even left them cell phones in order for them to be able to connect with their families and with the staff. But for video visits, we used a platform named Univer. Univer is this device that you put on a TV screen here, and it really makes the TV screen a companion, an interactive companion. It's operated with a very simple remote control that is also a microphone, with which the patients can easily contact us or answer us if we call them, and they can talk with. So this is how it looked. This is the way we did all our daily rounds with the patients or spoke with them as we needed. As you see, they're holding their remote control and talking to this. And in this way, we could really easily connect with the patients, but not only speak to them, but also be able to see them. We use this platform to do some group conversations as well. This is Professor Gili Regev, the head of the infection control unit, explaining to them about COVID-19, about the isolation measures, about how they have to work, what will happen when they go home, etc., etc. We also use this platform to do family visits and sometimes even group family visits. And the next thing we wanted to do is to monitor the patients. So we left in the room tools for them to examine their own vital signs. We left them blood pressure cuffs, of course, thermometers, and pulse oximeters for oxygen saturation, and they would check their vital signs and report by phone or radio at least 3 times a day. But we also left under the mattresses another sensor, which is called Early Sense. This is also an Israeli company, Early Sense, located both in Israel and in Boston. And Early Sense is a contact-free continuous monitoring sensor that monitors heart rate, respiratory rate, and motion. But it's not only a stupid sensor. It also has an artificial intelligence-based algorithm that can predict clinical deterioration and show us if something is going wrong. I thought I had a picture showing how it shows it. The third thing we wanted to do was to be able to perform a physical examination. And for this, we also used an Israeli kit that's named TytoCare, which we gained a lot of experience using it. TytoCare is a kit, as you see here, that contains equipment to perform, this operates as a stethoscope and allows us to check the heart and the lungs, but it also has an otoscope and a way to see the throat and the skin, and it also has a sensor that checks skin temperature. So we left the kit in the rooms, and we also left in the rooms tablets with a TytoCare application downloaded already, so the patients do not have to download it themselves. It makes them easy to use. And as you see, the app is really friendly, user-friendly, and guides them on how to do the physical examination. The physician, by the way, can see, hear, or watch the results of the physical examination at the same time, or even record it and listen to it later on. So we found this thing very useful. As we began to have more and more patients flowing in, flooding in when we did have corona from Israel already in the next month. We had to open new facilities for corona patients. By the way, in this picture, you can see some nice application of Taito. In this picture, you can see how they check to see if the nasogastric tube is in place when they're not able inside, when we're with the full PPE, have the stethoscopes in their ears and on the other sides on the patient's body. They would do that, and the doctor outside would listen to see if when they inject air, they can hear it. So this is a new application of Taito Care. So in the beginning, we had one medical, we had treated medical isolated corona inpatients, but later on we opened an ICU, especially for corona patients in an underground. We opened a psychiatric ward, I think the first one in Israel for COVID-19 patients. And at the end, we had a whole building, including about 5 internal wards for COVID-19 inpatients. And in every one of these facilities, we had needed different tools to treat the patients. So what we found very useful in the ICU, but also in the special care rooms, were the InTouch telepresence robots that we already had in Sheba. And these are located either in the special care room of the regular ward or in the ICU. They allow us to communicate better with the staff when they're inside the facility. So as you see here in the ICU for corona, we had not, the control room was much bigger than our teletent. It had a lot of screens, and it allowed for many more people and staff and personnel. And the robots were inside the dirty, the infected area, and it really allowed us to let less patients inside. If you can see here, I don't think you'll be able to hear, but you see the physician consulting with a cardiologist, which is in his office. At the same time, she's looking at the patient, and the staff that's inside is coming also to hear the consultation. And the thing with this robot, it has a very, very good camera that can get really closer, and sometimes you can get a closer look than even if you're inside, especially with all the PPE. And you can see every little detail, and you can control it from the outside. So this is how we use our consultation robots. So that's for inpatients. But soon we understood that most of our COVID-19 patients will not need to stay in the hospital, because most of them will not be severely affected by COVID-19. So this is where we developed a system for home hospitalization for COVID-19 patients. What we did was using our Datos application, which is our telemedicine application we use in Sheba, and we created 2 programs. One basic program was allowing the patients to self-examine the temperature, the oxygen saturation, and to download it, to write it down in the application 3 times a day. They would receive reminders and daily questionnaires about COVID-19 specific symptoms. They will have a daily internal medicine specialist video visit, and we put an ID physician 24/7 on call for consultations. So this was for very lightly affected patients. We also created a program that is extended for a little bit more severely affected patients, in which we also checked blood pressures, and we gave a Taito for physical examination, and we used this kit that we gave them at home. So this was our way to treat from distance patients lightly affected with COVID-19. We mostly used it for treating our hospital personnel that was infected with COVID-19, because in Israel, most of the patients that are not hospitalized are treated by the health funds and not by the hospital. The third thing that we also wanted to do that was especially very important during the first lockdown that we had in mid-March in Israel, where when people could not come to Sheba to get their continued care for chronic disease, our oncological patient and all the others, pediatric, adults, internal, surgical, etc. we developed an easy way for them to get video visits instead of frontal visits. So we transformed all our outpatient clinics to video clinics, again, using our Datos application. So we had a very simple way of this is how the physician's screen looks like. You invite the patient, write down the name or the email. The patient will receive a text message with a link. And then using the link, they will be straightly transferred for a video call, video visit, without the need to download a special app on their side. So they would just need a cellular phone. They will receive a text message, and then we understood that not everyone looks at the text message. So we also send a phone call with a pre-recorded message that informs them that they have to press on this link. They would press on the link and be connected to our secure video visit. And as you see here, we're talking to the patient, looking at them, and on the other screen, we're writing down in the medical records, and they will receive, if they're a member of Sheba, they will receive the letter either in our online, or we will send it to them by email. So really, very quickly, we had almost 1,000 clinicians using our system. And when we did patient satisfaction surveys, we saw that the patients were really happy with the service. Almost 90% said they had high level of satisfaction of the service. So I just want to say that right now, we don't have lockdown anymore, and we see that some of the patients want to come to the hospital, surprisingly enough, and some of so this activity has decreased a little bit, but some of the services, especially the psychiatric, the psychologic, and many others, have continued to provide. Me, myself, in my pediatric infectious disease clinic, I do it as well. We continue to provide a lot of consultations by video, and in this way, patients don't have to come just for follow-ups, and they find it very, very helpful. So to sum it up, we allowed our patients during Corona. We used telemedicine tools to give medical care for the isolated Corona patients. We created a system of home hospitalization for lightly affected Corona patients, and we allowed for continuity of care for non-Corona ambulatory patients, which are most of our patients. Most of our patients do not have COVID-19. So we understood that telemedicine tools already allow us comprehensive solutions that are highly scalable. And I believe that some of the reason why we found it quite easy to scale this solution was the reason that because we were already using our platform. It was not widely used, but it was already integrated in our systems, and we knew what we wanted to do and how we wanted to use it. Of course, this time of crisis presents some opportunities, and was a great opportunity for COVID-19 for telemedicine. And I think it can be remembered as a turning point for digital transformation in general, but specifically telemedicine. We understood that telemedicine is not a constraint, and that's how we see it now. It has the ability to give a lot of value to our caregivers and patients, and to allow for better quality, efficacy, and accessibility to healthcare. And we changed our vision, and we understood that now in Sheba, we wanted to widen the term continuity of care, and even the term of hospital. We changed the term of hospital in which geographical boundaries are no more relevant. So we wanted to create impact using harnessing telemedicine, and we want to create impact with it globally, financially, and not less important, we wanted to create a social impact in a way that we can provide very good medical services of Sheba to patients wherever they are, even in rural places, and even we wanted to do a lot of efforts to provide it to everyone, those in need, those who don't have the possibility to get very sophisticated tools or have other difficulties, physical, language difficulty, or others. I found a very nice quote that I like, so I wanted to read it to you. The beauty of telehealth is its ability to transgress many barriers that mankind has erected: geographic, time, social, cultural, and political, giving it the potential to achieve healthcare support for anyone, anytime, and anywhere. So with that, we've decided to develop a new concept and create a new hospital within Sheba. We called it Sheba Beyond. It's Israel's first virtual hospital, which is the one I'm now trying to build and I lead in Sheba. And if I have a few more minutes, I can talk a little bit about that. Do I have a few more minutes?
Yeah, Dr. Barkai, please go on.
Okay, so I will share another screen. Sorry. Okay, so a few words about Sheba Beyond. Can you see it?
Yes.
Do you see my presentation?
Yes.
Great. So really, we've tried to work on Sheba Beyond, and we opened now Sheba Beyond, and our vision really is to use telemedicine to redesign healthcare of the future, to be of the highest quality, innovative, tailored, and accessible, as I told you before, breaking the boundaries of space and time. And we want to provide advanced healthcare services to its patients everywhere in Israel and throughout the world, by the combination of leading clinicians that we have in Sheba, empowered by the technologies to create added value with both of these. I think both are very important, not only the technologies, but Sheba's medical specialists that are very highly qualified. So we found 4 business engines that we want to scale using telemedicine. The first is we call Sheba Hybrid, which is a model that we created for chronic disease management. I will show you in a second. The second is a model that we created for supporting local or rural clinics by sustainable collaboration. We've developed models of home hospitalization, and of course, we offer expert consultancy services. So just a little bit about our chronic disease management system that we mounted. We have, I think, a general model that we can tailor-made to several chronic disease, and I'll show you some example. First of all, our model talks about being a patient being managed by a senior specialist physician with a case manager that is a nurse, and we provide online continuous care. But it includes reaching out by the case manager, not just waiting for the patient to call us, but proactively reaching out for the patients. And we provide a holistic solution by creating a multidisciplinary team. And for that, we're using state-of-the-art telemedicine technologies for home monitoring. So we have home monitors of several kinds in which we can collect data that provide us extra value and more information between the visits themselves. So a few examples of what we've started already working on. First project is pediatric lifestyle. It's meant to treat obese children or with mild or moderate obesity. And I think now during, since in Israel, during lockdown and all this period, children did not go to school. Schools was closed in Israel. So all the children stayed in their homes. Sometimes they had Zoom or from distance schooling. So they lost their daily routine. They don't eat well, they don't sleep well, they don't do physical activities, they don't go out. So I think now every child in Israel needs this service, not only obese children. So our goal is really to decrease the BMI, their basic metabolic index, and also lifestyle improvement by increased physical activity, improved nutrition. The patients are several, and we have a clinical team of a senior physician, Professor Gal Dubnov, who's a pediatrician, but also a specialist in sports medicine. We have a nutritionist, a physiologist, and a psychologist. We're also using in this application, since it's children, we're using a gaming application that rewards them to increase the motivation with small rewards. We use the smartwatch and the Datos application to measure their steps and measure their sleep and physical activities during this period. Another model like this is also, I won't go into the details because I think we're beginning to lack time. So we have another model with vascular surgeons for preventing amputations in patients with diabetic foot. Israel, I learned that Israel is one of the worst places in the world that has a lot of amputations in diabetic foot, and we're trying to decrease this rate, high rate of amputations. So patients that are discharged after limb catheterization will stay home with a multidisciplinary team, and again, a smartwatch, wounds monitor, continuous glucose monitor if they need, and a monitoring app to try to increase adherence to treatment and decrease the need of amputation. We're opening now a pediatric pulmonology program for children with cystic fibrosis and ataxia telangiectasia, which is, I believe, is quite a rare disease. I don't know if you have it in Nepal, but these children also suffer from chronic lung disease. And in this case, they have also a clinical team that's multidisciplinary, but including a lot of distant physiotherapy that is really important for them. And we also have a special clinic for diabetes, type 1 diabetes and type 2 diabetes, with the same kind of multidisciplinary prolonged team managed by a case manager. A new service that we're opening now, we're getting really into the geriatric population, which are suffering a lot during COVID-19. And we're opening a psychogeriatric service, which treats not only the patient, but also the family caregiver, which sometimes suffer a lot of burden of the disease. And we also opened with a team of multidisciplinary team and telemedicine application and a smartwatch to try to treat better and make them cope better with the multiple diseases they're suffering with and the dementia. Another one is Parkinson's disease, just a little bit the same. I won't go into it. Another program I wanted to talk to you about is a program that's already operating in Sheba for several years. It had a few hundreds of patients. It's now reimbursed and endorsed by the Israeli Ministry of Health, and now they're taking it to other hospitals as well. It's a program of remote cardiac rehabilitation. It's a medically supervised program designed to improve cardiovascular health in cardiac patients. So its goal is to take patients after heart attacks or patients with heart failure or following surgery, and to help them increase their cardiac performance and physical and mental health. And we're using a smartwatch and a tailor-made program where they can see their results or the way they operated in the Datos application, and the physicians and the multidisciplinary team can see all the information regarding the physical activity. And it's already operating, and we also it was published that they have better physical health and mental health before and after beginning of the program. And usually a program of cardiac rehabilitation in Israel is 6 months, and they show that it's as good as or non-inferior to regular cardiac rehabilitation when they check in the objective metabolic test that they do for this. Another, I think I talked a little bit about it, another platform that was developed in Sheba. This is something that we really developed in Sheba, but we're using it as a service already. It's called Rehability Online, and it's a service that provides physical, cognitive, and mental rehabilitation, also with the individual tailored exercises and programmable levels of difficulty that can be used both online with instruction of a clinician and offline for independent use. We've already had more than 40,000 patients with different dysfunctions using this online platform, and this was developed by Sheba. It also had been published in the literature. Another program that we're starting this week is Halfway Out, we call it. It's a program that's intended to dismiss home earlier on surgical patients after an operation. We're actually giving them a smartwatch and blood pressure cuff and the DATOS application, and they can go home earlier and report the symptoms and being monitored until they follow up. Usually they stay longer in the hospital, but until when they come back for follow-up, no one knows what happened to them. So this way we can also first time let them go earlier on and then monitor them in between and know also they have a case manager, and if something goes wrong, she can get the picture quicker and know that they have to come back and maybe can prevent complications of surgery. Another program that I want to talk to you about is something I also mentioned before, the home hospitalization for psychiatric patients. It's a service that's already operating for more than a year with more than 100 patients, and it's for patients with mental dysfunction that live with a caregiver and are not at risk for self-injury. When they come to the hospital and it's decided that they should stay in the hospital, we let them in for just one night, in which we do a program, a treatment program. They meet all their team, they receive a bag with all our gadgets, smartwatch, a tablet, a smart medication box, and then they go home. They go home and continue all their visits virtually with their clinical team, with the whole clinical team. And the first time of the first few weeks, maybe it would be more intense, so it would be like hospitalization. But when they get better, they continue and like ambulatory visits, about once a week or once every 2 weeks. We've also launched another service of home hospitalization with geriatric nursing homes, in which we've combined to keep these patients at the bed in the nursing home when they need hospitalization. So they will come to our ER, they will meet Dr. Gadi Segal, which is the head of one of our internal wards. He will do a program and send them back to their nursing home. And then every day they will meet and talk with video with the team and the patients. They will be checked with Taito, and they will be monitored from distance with early sense. And this way we control the medical, we do the medical work, we do the medical program where we're doing all this. And in the nursing home, they will have nursing services that will give medications, will take vital signs, and the patient will not have to leave his home. We're also starting now a project with Mexico and maybe other countries as well of producing a medical kiosk. And this is for distant countries where in rural areas they do not have medical staff. So we're helping them build a local kiosk to enable the residents to be checked using advanced technologies and receive medical care by a physician afar. So it works that the families or the patients will come to the kiosk. Some kind of caregiver, it can be a nurse, it can be even, I don't know, a community person that helps them with the technology. They will be communicated by video to a physician in their country in a distant hospital, but only when they would need another consultation, a specialist consultation, we will give the specialist consultation. We also do the consultation on the protocols and the guidance on the technologies and how to build this service. We understood also that telemedicine needs different training. So these patients will need all our medical staff that will start giving video visits to their patients or providing services through video will undergo an online telemedicine course in Sheba for medical staff, all the medical staff, for best practices and improvement of specific communication skills, because as you know, the communication skills needed for video visits are different than frontal visits. And the courses include frontal teaching, as well as live simulation with actors that do some scenarios of telemedicine encounters. And we also provide a lot of expert consultancy services. Thank you. So this is in short what we did during COVID-19 and some of our future programs. I will be happy to take questions if you want.
Yeah, thank you, Dr. Barkai, for your very insightful presentations, and we got to know about a lot of innovations, and of course adversities and crises are always an opportunities for innovations and for improvement. So we have a few questions from here. There are questions related to the technologies, there are questions related to the management. So I will ask you, I'll club the question and ask you the questions. We have question from Mr. Arun Nupani, and he has asked if anyone who is from the remote part of Nepal can consult a doctor in Israel via a virtual hospital. And
excuse me, which one? I'm sorry. Can you repeat the question?
Can someone from remote part of Nepal consult a doctor in Israel via a virtual hospital? That's one of the question.
Okay, so yes, we have to do some kind of cooperation. We have to check. What's easier is to do a physician-to-physician consultation, because if we want to, we have to have a system of someone in Nepal sending the patients to us, and be, you know, we have to be able to report to a physician and to talk to a physician. So it's easier when we do a cooperation with a medical corps, medical hospital, insurance company, I don't know, and we make a cooperation together, and then we can do this thing together. But of course, we do also from distant consultation. We have to check about legal issues. I don't know the regulation in Nepal, but can an Israeli physician with an Israeli license provide medical care to Nepali patients? What about prescriptions? All these things we have to work out and find together a way to promote. I think everything is we can do everything, but that's easier if we have another doctor at the other side. We can give the consultation to the doctor, and the doctor will give, you know, the prescription and all these things. So it's easier legally to do when a doctor, not only legally, but I think it's best if the physician that will give the medications there will know which medications you can use and you cannot use, which services we can provide or not. But definitely we can do consultations to Nepal, and I would be happy if someone wants to operate to do some cooperation like this. Please contact me and we'll find a way to do that.
Yeah. There is another questions related to the technology, Dr. Barkai. The question is from Mr. Arun Nupani and Dr. Sailendra Duwal. So what about the AI tools in mobile phones for diagnosis of the types of cough, or maybe the voice and measurement of heart rate and respiratory rate, and also if you are using any software for registration?
So for registration, we're using our hospital software, and when still not fully integrated with this. So for registration, we have we're a big hospital, and everything has to be registered in our EMR and the administrative services. So we're using our own services. Regarding the AI tools in the mobile phones, we are still not using many of them. We're using the steps, the activity. Our plans is, of course, we're already collecting the data and learning from it, but our next step would be to use AI. Regarding diagnosis of cough, voice, etc., we're doing some, we did do during COVID-19 an investigation with a company using voice to try to detect COVID-19. We're still analyzing the results. We've been having a hard time to make people record their voice at home when they were sick. but we did. We're getting into it, but it's not on the level of production. It's still R&D. So we're getting into it. We are also starting another work with another company, Doc, for respiratory of oxygen saturation cuff and stuff like this for respiratory patients, but it's still in investigation phases.
Now there are a few questions that are related to the management and how actually you started and everything. So how was it economically when you started this virtual hospital, and then whether it was just the hospital staffs that you enroll into your home hospitalization system, or and if there was any, what about the medical legal issues concerning telemedicine?
So it's a lot of questions, different questions regarding reimbursement. Okay, the system in Israel is that we have 4 big health funds, and every citizen in Israel, not citizen even, every person living in Israel has to be in one of the 4 health funds. We have a national healthcare regulation. Okay, so everyone should receive. We're a state hospital, so everyone has insurance in Israel. And what we usually do with some of the programs, for example, the home hospitalization with psychiatry, is that we cooperate with one of the big health funds, and we do we cooperate with them to find a way to be paid for that. They will pay us for a certain service, and then we can offer it to their patients. Okay, so we have it for several projects. For just outpatient visits, it was decided about a year and a half ago in Israel that every patient that needs to come to the hospital and they have their health fund pay for this visit in the hospital, we are able to choose if they do it virtually or face-to-face. So we have now an easier way to provide video visits to our patients. So if the patients will receive from their health fund an agreement to pay for that service, we can do it virtually. So that made everything easier for us. Regarding home hospitalization, we have to combine with them for a special agreement on that. This is regarding the reimbursement part. Regarding the regulatory part, we're dealing with it all the time. And every time that we want to open a new service that's innovative, we have to ask the Ministry of Health. For example, home hospitalization. For a long time, the Ministry of Health would promote home hospitalization, but not remotely. They would say, yes, we'd love patients to go home, but the health funds will need to send a doctor to their house every day, send a nurse to their house every day. And we wanted to do part of the things from distance, being checked with hospital doctors, which we believe are very good. Okay, so we're working with the Ministry of Health to try to change the regulations. And I have to say that COVID-19 did us a good service, because many of the barriers went down, and now the Ministry of Health understood that they will have to allow us to do new things, and we're using this opportunity to get things advanced now.
So what about the medical legal issues with this kinds of setup, Dr. Barkai?
So I believe it's the same issue. So as I started to talk about, the medical legal issues we have a regulation regarding it. We have, for example, to make the patients sign to agree that they can receive these programs. Some of it we deal with by requesting the Ministry of Health to do that, and they would allow us. This is part of the medical legal issues that we're dealing with, except, for example, with home hospitalization. Many times we involve them early on when we design a new program and get their agreement to do that. But I believe, also all our platforms are HIPAA compliant, and we were talking about it. We're dealing with every of these medical legal problems. Sorry.
Okay. So, what were the responses of the caretakers, before the lockdown and after the lockdown? I mean, was there any difference, or do you have any data on how it was perceived or taken before the lockdown and after the lockdown?
Okay, so I think I'm telling you, it was a great opportunity for us, this lockdown, for enhancing telemedicine. Before, we did have, like everything in every organization, there are early adopters of innovation, and there are intermediate adopters of innovation, and late adopters, and there will always be people that don't want to use it, physicians and patients as well. And so we had, as I told you in the beginning, we had a few of the physicians that were really keen to try new things and wanted to develop, and we started with them because we knew they would like to do that, and we started with younger patients and the ones that fit with it more. Of course, during lockdown, many of them had to do it because they had no choice. They will have the clinics with no patients, and the patients would like to see their doctors and could not come. And some of them, when they tried it, they understood it's very good for them. But I have to say that not all of them. Not all of them. Some patients and some physicians still don't like it. For example, our orthopedic surgeons, they're not ready to use it. They won't use it. They say, I can't agree. And I, as a doctor, I understand it very much, because for us, it's really so unnatural not to see the patients, touch them, be in physical contact. It's part of our DNA as physicians. So we have to do a transformation, a true transformation, and start to doing things from distance. And I think many people really liked it when they started to do it. Some did not like it. And I saw there was one question, how many people continue to use this service. But I want to say, in our peak lockdown, we had about 750 visits per day of telemedicine. And then it went down to 250, 300 a day, to about less than a half. Okay, people wanted to come back and physicians would not want to do it. And now we're seeing it increasing day by day. So now we have 350, 400 a day. So people are continuing to try it and use it now, and use this a platform now. So we're still continuing. I think things will not return to what they were before. Before COVID-19, we had less than 50 visits per day, even sometimes less than 10 virtual visits in the hospitals per day, and now it's in the hundreds. And we have every day, as you saw, many new programs that we're starting to develop.
Yeah. Yeah, Dr. Barge, as the cases are rising in Nepal, we also see that telemedicine could be one of the opportunities for us to manage cases from the hospitals and from the home itself, where many people are actually managed at managing themselves at home isolation. But do you think a setup like telemedicine can be a long-term solutions, or can be started when in a resource poor country like us? Do you think we will be able to do a telemedicine service without innovative equipments or anything, or will we be only be able to do the basic services?
So as long as you have internet in your countries, and many of the patients have cellular phones, I believe that you can do a lot. You can do a lot, and you can apply a lot of services using telemedicine, because I believe even in low resources in your place, you do have internet in almost everywhere. Am I right? Do you have internet everywhere, and many people are using, or at least even if you have a local community clinic where you can have internet, and it's like I showed you a small kiosk. If you have a small community, a place, a clinic where you can put a few things, very simple, not expensive, I believe you can do a lot and help a lot of people that way. It's not easy to implement, but it's doable.
Thank you very much, Dr. Parke, for such a insightful presentation again. And I would like to thank all the participants for their questions as well. And for maybe for another 5 or 10 minutes, if we have someone who want to share their experiences related to telemedicine or management of COVID, we have another 5 or 10 minutes for that.
Yes. I just wanted to say, that, first of all, thank you, Dr. Galia Bakai, for the presentation. But I just wanted to say that if anybody has questions, even a little bit later, we do have an email, which we called Corona Israel Nepal, all in one word, @gmail.com. Please do write to us, and we will forward the questions to the people who need it. So it's coronaisraelnepal@gmail.com. Please do write to us, and we will really relay to every question in the best way possible.
I also shared my email in the chat, so if anyone wants to ask more questions, they can do it.
Sure. Perhaps the ambassador of Nepal in Israel would like to say a few words to us. Or Eli, would you like to say a few words? Dr. Shakia, would you like to say a few words to us?
Thank you, Ada. And thank you, Dr. Galia. It's really very nice to listen from you. And you presented very nicely. It is very comprehensive for me. I didn't understand all, as I'm not from this background, but hope that people from Nepal, Nepalese doctor, they already they have some ideas, and they have experience on it. Some part of Nepal, they use this telemedicine, as I know. I am wondering to find some collaborations between Nepal and Israel in telemedicine also as well. If it could be possible from Seva Hospital, that will be wonderful. As you are already here, we have been talking so many times in virtual meetings. So if you can do some collaborations from Sheba Hospital to any hospital in Israel, that will be very useful for us, both of us. And I would like to share you here one good news, that I went and met Health Ministry Department. She is Professor Ronit, and she was director in Ministry of Health, and we talked. We have some good conversation between us, and she wants to help Nepal, and she wants to connect with Ministry of Health in Nepal. And I already received the contact person from Ministry of Health from Nepal, so that she can contact with Ministry of Health here. And we had yesterday, 2 days before, we went and meet, and yesterday we sent even request letter to Ministry of Health in Israel. Any from medical sector, medical cooperation, what can we do from G to Z? So we are expecting a lot with this connection, with it talk. I hope that we will have something between Nepal and Israel in medical sector. I hope so. It is really very wonderful having with you all time and again. Thank you very much, and wish you all the best for this. Thank you very much.
Eli, thank you, Dr. Shaka. Eli, would you like to add a few words as a doctor who's been really involved in the corona epidemic in Israel and knows Nepal so very well for so many years, and a real friend of Nepal? Please add a few words.
So first of all, I'm very happy to renew these meetings, and I hope you had nice holidays. I think it's still Tihar in Nepal, Am I
Yeah.
correct?
Yes,
Okay,
yes,
so
happy
it's
to have.
very nice
Happy
that
to have.
despite, yeah, so despite Tihar, you still came to listen to medicine. I want to thank Galia Bakai for the excellent presentation. And I think really telemedicine is something which is so highly needed. And actually, just before the corona broke out, I was visiting Nepal and I talked about telemedicine without connection to corona. Now with corona, it's become obvious that it's so really highly needed. And I'm sure that the corona, you know, it's a bad situation having the corona with us, but there are some good aspects which may come out of it. And one of them, I think, is the highly developed telemedicine, which we will continue even later on. And I agree, I myself, I do a lot of telemedicine here in the hospital, and people like it. So it's really very convenient, you know, save time, save the traffic jam that people suffer. And for many of them, which is only just follow-up, not the first initial meeting, it's really convenient and easy for both sides. So again, wish you good time, and thank again, Galia, for joining us. And just to let you know, Galia is a great traveler all around the world, except of Nepal. So at the moment that Corona will be seized,
I have
Nepal
to
will
go to
be-
Nepal. This
we
is one of
would
my
like to
dreams.
welcome you.
Yeah.
Yeah, you must go to Nepal after Corona. We would like to welcome you to Nepal. And for Professor
I hope Eli takes me next time with him.
Yeah.
And we spoke before Eli left Israel to go to Nepal. We talked that even there was no corona at that time in Nepal. Please talk about this corona COVID if we can come back. Even it is not appeared at that time, but it may be appear in future. I told you, yes, Professor Eli. Yeah, yeah. I hope that we can jointly combat this COVID situation.
Okay.
Okay, thank you.
Thank you all.
Thank you so much.
Bye-bye.
Thank you. Bye bye.
Everybody, bye-bye.
Bye.